Hello, my name is Tracy Goodman, and today I'm joined by our healthcare pioneers in showcasing of SVT of 2023. I am joined by Ms. Alex Wise and Mrs. Chloe Ford. They are arrhythmias nurse specialist team at the Barts Heart Centre in London, UK. Thank you.
My name's Alex Wise. As Tracy said, I'm one of the arrhythmia nurse specialists here at Barts Heart Centre in London. And I want to talk to you today about our end-to-end arrhythmia nurse specialist-led pathway for SVT diagnosis, assessment and management. So we work here in the city in London. Barts Heart Centre is one of Europe's largest cardiac centres. We perform around 1,400 ablation procedures a year. SVT, supraventricular tachycardia ablations, account for 1/3 of the procedures that we do. That's around 400 to 500 per year. We've got a very good track record for developing innovative practices. And one of these was that we developed a nurse-led end-to-end pathway to diagnose and manage patients with SVT. So to start with, we run a one-stop arrhythmia clinic. This is nurse-led, staffed by 6 arrhythmia nurse specialists and supervised by 3 electrophysiologists, consultant cardiologists. Patients are referred to this clinic with palpitations, diagnosed arrhythmias and syncope. The referrals to this clinic come from the 3 trust emergency departments, that's Newham Hospital, Royal London and Whipps Cross, and other secondary and tertiary care specialities. 1,363 patients were referred to this service in 2019 to 2022. 37% came from general practitioners and 63 came from the hospital ED departments. 12% of those came with SVT, so around 164 patients. So what do we do in this clinic? So patients are referred to us. We'll do a full clinical assessment. They'll have an ECG and an echocardiogram on the day, along with observations. We're able to review the results of those on the day and go through those. For some patients, we can diagnose straight away. For others, we have to organise further investigations on the line. Almost always for SVT, if we've had an ED ECG, we can diagnose there and then. So treatment outcomes for SVT from our clinic: 61% were discharged with advice and suggested medication if required. 28% were listed to have an electrophysiology study and ablation. 11% were referred to cardiology clinics or other relevant specialities if we'd found other conditions or issues in the investigations that we'd ordered. Patients that were listed for an electrophysiology study and ablation were provided with an information pack and an online link to access a bespoke animation video on the procedure. This is the website, and we do have a password for this if patients are interested. Following their procedure, patients are then booked into our virtual post-ablation follow-up clinic. This is nurse-led run by the same 6 arrhythmia nurse specialists that run the one-stop, supervised by 1 EP consultant cardiologist. We review the SVT ablations at 3 months, and this is remote, via video or by telephone. And normally, if all is well, we will discharge. Throughout the patient journey, an advice telephone line and a generic email inbox are available for patients during working hours. So ultimately, our nurse-led end-to-end pathway has enabled a streamlined approach and journey, and it's reduced referral to treatment waiting times with a median referral to appointment interval of 38 days. This picture gives you an overview of the whole service. So I'd like to pass you over to my colleague, Chloe Ford, who's going to talk you through a case study from one of our clinics.
So this was a patient that I reviewed in the arrhythmia one-stop clinic. This was Mrs. M, a 48-year-old lady who presented to one of our emergency departments with palpitations. At the time, her 12-lead ECG confirmed SVT at 193 beats per minute. She was successfully cardioverted to sinus rhythm following the administration of adenosine. She was referred to our clinic and reviewed with a 12-lead ECG, which showed sinus rhythm with no pre-excitation, and she had an echocardiogram, which showed a structurally normal heart. So this is her ECG from her A&E admission, showing SVT. During our clinic appointment, treatment options were discussed for SVT, and Mrs. M was keen to proceed with an EP study and ablation. The case was then discussed with our EP consultant and she was waitlisted for a procedure. She then came into Barts and had a slow pathway ablation for AVNRT in September 2022. She was then followed up with myself again in the virtual clinic in January 2023. At this point, we'd had a 12-lead ECG, which showed sinus rhythm, and she had no further symptoms of palpitations. We then discharged her from the virtual clinic, and Mrs. M was reviewed by the same nurse, myself, from start to finish.
And this is our whole team with our consultant colleagues. Thank you very much.
Thank you.
Thank you for your presentation, ladies. Very informative. I've just got a couple of questions to put to you. First of all, do you think nurses are an untapped source of expertise and that their skills should be utilised more frequently to help reduce waiting lists?
Yes, I think the service that we've just showcased is a very good example of this. I've been an arrhythmia nurse specialist for 15 years, and I've seen over the course of that time numerous different types of clinics set up by nurse specialists that have taken over from what was a medical approach or a medical structure. I think it's allowed, certainly in our trust, our emergency departments to have a streamlined service to come through into a tertiary centre to have patients seen quicker. We know that many of the consultant clinics and pandemic have very long waiting lists, and I think the more of us that can do this, the more patients that can be seen.
Thank you. Perfect, thank you. Did the nurses require any specific training in SVT?
So certainly from my experience, I was originally British Heart Foundation funded, all the arrhythmia nurses on that cohort and around the country were put onto a master's level module to help give us more experience, expand our knowledge and our diagnosis technique for arrhythmias. And I think over the last 15 years that's carried on. So when Chloe joined our team, for example, it was important that one of the things that they did to start with is go on to a master's level arrhythmia course. And that's not just diagnosis, but that's management of arrhythmias as well. At the time, there was one running in London and up in Middlesbrough, and I'm sure that the Middlesbrough course is still running. So there's courses, and I think experience. So our nurses that start in the team will sit in with consultant clinics and our own clinic for a period of time, and we have objectives they have to pass before they come out to see patients independently.
Okay, that's wonderful. If there were any concerns, or if the patient requested one, are they able to see a doctor at that time?
Yes, absolutely. So when we are running our clinic, we have a consultant that is working alongside us. That's normally accessible if needed. And if the patient had requested to see a consultant, then that's something that we can definitely arrange if needed.
Wonderful. Thank you very much. You've both presented a very informative presentation today, and I'd like to say thank you on behalf of Arrhythmia Alliance and congratulations. Thank you.